my name is Valate. I am with Medical Education Angels, and we are doing Basic Dysrhythmia, Learning to Read Heart Rhythms. Basic Arrhythmia is a really fun course, but if you don't work in the medical field, it can feel a little bit overwhelming because there's a lot of vocabulary that kind of goes with the course. There's also times where you can explain something really simple or in a lot of detail, and like a lot of things in medicine, some things have more than one name, which can make it challenging when you're trying to learn for the first time. As I am talking, I know I talk kind of fast, so I'm going to try to slow down, and every once in a while I get tongue-tied, especially when I need more caffeine. So forgive me if I say something backwards or wrong or I need to correct myself. It's just that my brain is probably moving faster than my mouth. Basic Arrhythmia can be a really fun class. It's learning to read your heart rhythms, and I'm kind of a dork, so I think rhythms are a lot of fun. But if you have never been in the medical field before, there's a lot of new vocabulary that can go with basic arrhythmia. Sometimes there's two different ways to say the same thing, and sometimes you can explain things in a sort of general way or with a lot of detail. So in the packet that you have, there's 4 pages of vocabulary, and I would suggest that you make flashcards. As we go along and as we talk about new terms, make flashcards of them that you can review and study to help you really get a handle on that part of the course. So I think now we're ready to kind of start talking about our heart and the electrical system and do just a quick little bit of review. Most people, if you've been through at least high school biology, know that the heart is made up of 4 chambers. And really quick, it will become apparent that I am not an artist, so forgive my drawings. So we have the right atrium, the right ventricle, the left atrium, and the left ventricle. Just as a point of review, blood comes back into the right side of the heart from your body. The right side of the heart sends it out to the lungs. Blood comes back from the lungs to the left atrium, to the left ventricle, and then out to the body. Okay? That's sort of the mechanics of what's happening. In basic dysrhythmia, we're talking almost exclusively about the electrical system and what's happening with the electrical part of the heart. Okay? So in our heart, we have this little node that starts our electrical system. It is called the sinoatrial node. People call it the SA node for short. Okay? The SA node is sometimes called the heart's natural pacemaker. It has a natural sort of intrinsic firing ability of 60 to 100 times a minute. Okay? From the SA node, it goes down these little internodal pathways to your next little hub called the atrioventricular node. Okay, we call it the AV node for short. The AV node has sort of a natural intrinsic firing rate of about 60 to 100 beats per minute. From there, there's this little bitty stubby piece here called the bundle of His. Okay, I laugh every time I say that because I do not know why you would name something His. That just sounds strange, but somebody probably had a good reason. From the bundle of His, the electrical system breaks off into the right and left bundle branches. Okay, from the bundle branches, it goes into these little long kind of spider webby parts called Purkinje fibers. Purkinje fibers. Okay. So I want you to think of the electrical system like a freeway. You know, when you're on the freeway, you can go fast, right? The cars are close together, everybody's going really quick. But when you get off the freeway, you could still get to where you're going most of the time taking side streets, but it's going to be slow. The same is true for the electrical system. Things can cause the heart to contract by going off the electrical system. It's just that when you stay on the electrical system, everything is nice and quick and tight. And we'll talk about what the differences are in that. Okay. So what you see when you are sitting at the monitor or you've hooked up your patient to a heart monitor, what you see as this electrical impulse travels from the SA node down our pathways to the AV node is something that looks like this. A small, round, upright little bump. And we have named that bump the P wave. Okay? After your P wave, there's a little pause. And the pause is just your heart holding that stimulus in the AV node for just a few milliseconds so that the atria can finish draining their blood into the ventricles before the ventricles depolarize and contract. Okay, so there's a little pause. As it comes down our bundle of His and out our right and left bundle branches, we get something that looks like this. Okay? We call this the QRS complex, and then we call this other little hump on the end the T wave. So let's talk about what's happening here. We use the word depolarization and repolarization instead of contraction. Just like if I flip on my light switch, I am pretty sure that light is going to turn on. But the day may come when those light bulbs are burned out and I flip on the switch and those bulbs don't come on. But I still have electricity flowing through the house, through the switch to that socket. It's just that the socket didn't respond because the switch was, the bulbs were burned out. So when we have our P wave, we know that the atria is contracting. As long as our patient has a pulse, right? We know that the atria is contracting, but we don't say contraction, we say atrial depolarization, okay? When we have our QRS complex, that's our stimulus that went down the bundle of His, the right and left bundle branches, and out to the heart. This is ventricular depolarization, contraction, okay? Just like something depolarizes, it has to repolarize before it can do its thing again, right? So the T wave is ventricular repolarization. Now, you might ask, don't the atrias repolarize? Yes, they do. But that you can't see it because it happens inside the QRS complex. That's all. It's there, you just can't see it. Don't worry about it. Okay? I want to say one little tiny thing about the way we monitor these and the leads we use to monitor them, and then we're going to actually talk about it again later because it makes more sense the farther you get on in the course, okay? So most people know that we monitor our heart rhythms through electrodes, those little tiny patches that go on the body, and we hook our leads to it, and in one of these videos we'll show you what all those look like. And some systems have 3 electrodes and some systems have 5. And if you go to the cardiologist, they'll actually hook up 12, and all those different lead systems are giving you basically the same information. But what they're doing is they're showing it to you from a different angle. So just like if I'm standing here in this room, you could take a picture of me from that window and see, you know, the right side of me. You could take a picture of me from the left window and see like the left side of me. You could take a picture of me from that door over there and sort of see the back side of me. It's still me in all the pictures, and if I jump up and down, I'm still jumping up and down in all the pictures. It's just that each lead shows a different side of me. That's all. That can be really important when we're thinking patients have cardiac disease or might be having a heart attack. But in general, for interpretation of all of these rhythms, we want to be looking at lead 2. So our leads have a positive and a negative. So when whoever's telling you to put the leads on wants you to put them in a certain place, there's a reason. And there's pictures in all your handouts that go with this that your instructor is going to go through with you and make sure you understand, okay? Even if I have 5 leads on my patient, my cardiac monitor is really only using 1 or 2 of those leads at a time, right? It's just taking this one picture, this one picture, this one picture, and then if it needs to switch because you change it on the monitor, it'll go to take another picture from another direction, okay? There's a negative and there's a positive of the limb leads, okay? The ones in the middle, they're called a unipolar lead. They kind of look at it more as a trans section versus a cross, so it's the positive and negative within itself, but I don't think that's so important to know. The only thing I want to say is that if you reverse you're negative and you're positive, things on your EKG can look upside down. Because as your heart contracts towards the positive electrode, it makes things on your EKG move up. So if you had them reversed, your P wave might look down. Okay? So the first thing I want you just to keep in mind is if your tracing ever looks funny or abnormal, first thing you do is go check your patient, change your leads, and make sure everything is hooked up in the right spot. Okay, makes sense? We good? So now you've got some pages in your workbook, and I want you to label them, the P, the Q, the R, the S, and the T. There's one thing that you will find. Not everybody has a Q wave, and everybody's looks a little different. So you might have P, no Q, R, S, T. You might have P, little tiny R, big deep S, T. You might have all those things. So the R wave is always your first positive deflection. May or may not have a Q. And your S wave always follows the R and then T. Okay? P, no Q, R, S, T. Same sort of thing. P, R, oops, R, S, T. Whether it has a Q or not, we still tend to call it the QRS complex. Okay? All right, practice those. Okay, so now that you know what's the P wave, the QRS complex, which is your R and your S and your T wave, we can talk about what things we measure on a strip. Now, most hospitals have a policy that you measure at least 3 things and you can determine the rate. Nursing schools, those sort of things, paramedic companies generally have the same requirements, but you should always check the policy where you work and know what you're expected to do for your job, okay? So the first thing that we can determine is our heart rate, all right? And I think for this, I want to show you a strip. So when we're talking about heart rate, there's actually 3 different ways to determine the heart rate from a strip. And I'm going to teach you 2. There's information on the other one and it's in the book, and I'll probably say a few words about it. It's just not my favorite, so I don't do it very much. Okay? When you first look at a strip, what I want you to kind of do is just sort of, in your mind, start looking, does everything look the same? So you can see along this strip, there's these markers, those little more dark little tiny boxes, and those are markers of time. It's just telling you that this is 1 second. 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds, okay? So that is the easiest way to determine your heart rate, is look at 6 seconds worth of strips, count the number of complete complexes, being a whole PQRST, 1 complex, and multiply that by 10. So we would go 1, 2, 3, 4, 5, 6, 7, we got almost 8. So we could probably say, we'd probably go 7. This strip is about 70 beats per minute. The next way to determine heart rate is to pick 2 points on your tracing. So we pick this point and count the number of little tiny boxes in between them. Now, when you're looking at your EKG paper, you will notice that it's this grid pattern of 5 little boxes, 5 up, 5 down, inside a bigger box, okay? Each little tiny box is 0.04 seconds of time. So in each big box, there were 5. So 0.04 seconds times 5 is 0.20 seconds, okay? So if you take this number of boxes you got in the middle, all right, let's say you got 30, and you divide that into 1,500, you end up with 50 beats per minute. The way that works is that there's 1,500 of these little teeny tiny boxes in 1 minute. So it's just a simple math thing of figuring out the time, okay? Make sense? All right. Now, as we go later on in strips, we might even talk about calculating the atrial rate versus the ventricular rate. This sounds complicated, but it is not, and I'll show you why. We knew our atrial rate was our P waves, right? The P waves were the contraction of the atria. So you could measure from P wave to P wave, count the number of little boxes, and you would know the atrial rate. If you measure from QRS to QRS, count the number of little boxes, you're going to know the ventricular rate. In most normal rhythms, they're the same. So most of the time they're the same. It's just when we get to later on things where they get a little abnormal that you might decide to do that. And it doesn't matter if you measure from the beginning of each one, the top of each one, or the end of each one, just as long as you're measuring from the same place to the same place on your two complexes. Make sense? So we've found a first way to measure heart rate. And right now we're looking mostly at rhythms that are pretty regular, meaning everything on our paper is evenly spaced apart. Those QRSs are coming at a regular interval, okay? The next thing we're going to look at is the three things that we have to measure on the EKG itself. And then you're going to practice, okay? And your instructor is going to make sure you've got this down. I know this feels kind of like a lot in the beginning, but trust me, if you do it like 20 times, you will know it forever and ever and ever, and then you'll never forget it, and you'll be like, oh, that's so easy, right? Okay, so here's our strip. It's kind of an ugly P wave. Hang on. There we go. Gotta have a pretty P wave. So the first thing we're going to measure is from the beginning of the P wave to the beginning of the QRS complex, and we call this the PR interval. We abbreviated the PRI, okay, but it's the PR interval. A normal PR interval is 0.12 to 0.20 seconds, which is 3 to 5 of those little tiny boxes. Okay? Next, we measure the QRS complex itself. So from where our QS complex leaves to where it returns, kind of to our baseline, is our QRS complex. And we still say QRS even if there's no Q. Okay? This, we want it to be less than or equal to 0.10, which would be 2.5 little boxes. Okay? There are some reference books that say less than 0.12. So if that's the reference book you have or that your hospital wants to use, that's fine. We're really not talking about a great, huge difference there. So whatever you like to do on that one is fine. Okay? The last thing we measure is from the beginning of our Q wave to the end of our T wave. This is called our QT interval. All right, that makes sense. Beginning of the Q to the end of the T, the interval of time between that. Now the QT interval is not diagnostic. And by that I mean there's about 17 different rhythms you're going to learn, and there is a rule for each rhythm. The QT interval doesn't really ever play into the rules, so it doesn't help you in determining this rhythm from that one. But it's still important to monitor. And one of the reasons it's important to monitor is that certain medications can make that QT interval longer. And when you have a longer QT interval, it can predispose you for certain dysrhythmias that are life-threatening. So that's bad news, right? That's not happy times, okay? The other thing about QT interval is it's really dependent on your heart rate. When your heart rate is slower, your QT interval is longer, just naturally. When your heart rate speeds up, your QT interval shortens, okay? So I'm going to tell you it is 0.30 to 0.40-ish, okay? It's not the most important thing. It's going to be close in there. You know, if it's a little bit longer, that's okay. If it's a little bit shorter, that's okay. The more important thing is that you're looking for a trend. If maybe the patient's QT interval yesterday was 0.36 and today it's 0.52, okay, that's a pretty significant change. That's what I'm looking for QT interval more. For changes, more so than the actual what it is today, okay? So now, we're going to go back to those strips that you wrote before, P, QRS, and T on. And there's more strips in your book. We have strips up the wazoo for practice. We have lots of happy practice strips. And I want you to measure the PRI, the QRS, the QTI, and determine the heart rate. Okay? And while you're looking at them, just make sure that it's marching out nice and regular. If you notice that it's not, make a note of that too. Okay? Okay, I'm hoping that your practice went good. If it didn't go good, you should pause the video and practice some more and make your instructor come and verify all of that you got your measuring down, okay? You probably need glasses because those little teeny tiny boxes are small, and God knows now I need glasses for these little teeny tiny boxes, which I really hate to admit out loud. But I'm trying to come to terms and accept the fact these days. It is what it is. But now that we know how to measure a strip, we can start interpreting some, okay? So I'm going to give you the rules for about 6 different rhythms, okay? And then we're going to practice on the strips. You're going to go back and forth, compare the rules, measure out your strip, and then give it an interpretation, okay? Easy, easy, easy. Good stuff. So the first 3 are kind of like a threefer. You know, they're kind of cool. So if my rate, right, is 60 to 100, that's normal. If my PRI is normal, 0.12 to 0.20, if my QRS is normal, less than or equal to 0.10, and my rhythm is regular, okay? If that is what it is, it has to be sinus rhythm, just normal sinus rhythm, okay? If the heart rate is less than 60, but my PRI is still normal, my QRS is still normal, and my rhythm is regular, it has to be sinus bradycardia. You can say sinus brady for short. Some people just write SB on their interpretation or SR on their interpretation. Some people say normal sinus rhythm instead of just sinus rhythm. Whatever you want to say is fine. Just more fun vocabulary to make it interesting. Okay? If everything is about the same, but my heart rate is greater than 100, my PRI is still the same, normal. My QRS is still normal, and I'm still regular. We are sinus tachycardia. Okay? First 3 so good? See what I mean? Kind of a threefer, not much difference in there. All right, the next one is about the same too. This one we give a little bit more variation on our rate, but it's usually pretty normal. It might drop down a little bit normal, but my PRI is normal. My QRS is normal, but my rate is irregular. It is sinus arrhythmia. Okay, and by irregular, I mean it's gently irregular. It's not like I have like beat, 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 beat. It's not like I have a bunch of really early beats or something. Sinus arrhythmia is typically following your respiratory pattern, so that as you take a big deep breath in and you exhale, your rate slows down just a little. But if you watch it for long enough, it's like a gentle speed up, a gentle slow down. So what you might see when you're measuring from your R to R is that these were 19 boxes, this was 19 boxes, this one was 23, this one was 23, then it was 19 again. Just a gentle kind of change. Very normal in children. Also kind of happens sometimes when people are sleeping really deep. Nothing to worry about. Okay? All right. We have a couple more, and then I'm going to put up a board, and we're going to freeze that so that you can work on your papers and get them all out. All right, so far we have sinus rhythm, 60 to 100, normal, normal, regular. Sinus brady, less than 60, normal, normal, regular. Sinus tach, everything is the same except my rate is greater than 100. And sinus arrhythmia, 60 to 100, 0.12 to 0.20, still less than 10, it's just irregular. Okay? All right. Couple more rhythms, and then you're going to practice. Okay. So let's say we have this next one where our heart rhythm can be either. It can be sinus Brady or sinus rhythm, right? So this could be anywhere from, like probably 40 to 100, somewhere in there. But my PRI is long. It's greater than 0.20. But my QRS is still normal. And my rhythm is still regular, okay? Well then, based on rate, if my heart rate's less than 60, I'm going to say it's sinus Brady with, if my rate is 60 to 100, I'm going to say it's sinus rhythm with. Now a long pure interval like this is just called a first degree heart block. That's all. So I would say it's sinus rhythm with first degree heart block, or sinus Brady with first degree heart block, or sinus rhythm with first degree heart block. All that's happening right now is that it's taking a little bit longer than normal to go from the SA node to the AV node. Just a little bit of slowed conduction. Often medication related. We probably did it to them. We probably did it on purpose. Okay? That's all. First degree heart blocks, nothing too exciting. Except that when you're first interpreting them and you're like, oh hey, I have a first degree heart block. But from a patient standpoint, nothing too exciting. Okay? So for our next rhythm, this one is just sort of where, well hang on, I want to backtrack. I want to do a different one first. Okay, so let's say we have same sort of thing, either sinus Brady or sinus rhythm, could even be sinus DAC, any of those. And our PRI is normal, 0.12 to 0.20, but this parameter was abnormal, okay? This parameter was greater than 0.10, okay? When this parameter is a little bit long, we call that a bundle branch block, okay? And so thinking about what's happening, okay, my normal conduction system, SA node, AV node, bundle of his, right and left bundle branches. For whatever reason, when this one is prolonged, remember our QRS was our ventricular depolarization, so our ventricular contraction. So if that number is greater than what it normally is, all that's telling us is that our conduction is a little bit slowed down here in our bundle branches. Okay? There is a way to tell if you are really, really curious whether it's the right bundle branch or the left bundle branch, and there's advanced classes that even tell you, which end of the right of the bundle branches and all that. It gets crazy. But this is just a basic class, and that's probably all you need to know, is that there's a bundle branch block. And that's pretty easy because that's just greater than 0.10. So if our heart rate was less than 60 and all of these parameters were the same, or 60 to 100, or greater than 100, PRI was normal, but this was the only thing abnormal, we would say sinus rhythm with a bundle branch block, or sinus Brady, the bundle branch block. Okay? All right. Now, sometimes your heart can get a little bit irritable, and things start to speed up and go really, really fast. Okay? So let's talk about what happens when things go fast. I'm going to change my pen, because I like to change my pen a lot. Because I swear, dry erase pens feel like they stop working. Like you use them for 2 minutes, and then it feels like it stopped working, but you shouldn't throw them away because you put the cap on them, and you don't touch them for an hour, and then they work again. It's irritating, or funny, or all at the same time. Okay, so let's go back to sinus tach. Sinus tach, our rate was greater than 100, okay? But our PRI was normal, 0.12 to 0.20. Our QRS was normal, less than or equal to 0.10, and our rhythm was very, very regular, okay? But what's the top end for sinus tach? I know you were curious. I know you were asking yourself. I know you wanted to know. So this is what I'm going to tell you. When you start getting to rates greater than 150, it's going so fast that your P waves and your T waves start coming closer and closer together just because it's going so fast. They get smushed into each other. And it can be hard to distinguish where's my P wave start and stop, or does my T wave start and stop? So when your heart rate gets greater than 150, you may not be able to see the PR interval. And if you can't see it, that's okay. You write not applicable, okay? But your QRS still should be normal, okay? And it still should be nice and regular. But at 150, we stop calling it sinus tach. We call it supraventricular tachycardia, or SVT. Okay? Last rhythm. This is so easy. Everybody knows this one because you've probably watched Grey's Anatomy or something. Everybody knows this one, right? Does not everybody know that one? Asystole. May they rest in peace. That's all I'm going to say about that. No. So asystole is our last one. True asystole is not completely flat. If it is completely flat, your person's probably been dead for like 4 hours. You probably should have checked on them a long time ago. True asystole isn't completely flat. It has a little bit of curve and movement to it. Not a lot, but just a little bit. If your line is completely flat, make sure your leads aren't off. Make sure one of your patches hasn't pulled off or the lead hasn't pulled off. If your patient is sitting there, they are not sitting up and talk to you, they're not an asystole, I promise. Okay? Okay, so this is just what I had written up there before, but all condensed here for you to look at as you are practicing your strips. That way you don't have to flip back and forth at your notes and what I'd said in other parts of your papers. So if there's one P for every QRS, you already are going to know in your mind this is some form of sinus rhythm. This is sinus something. Then we start our deduction process. We start ruling them in or out. If our PRI is normal, our QRS is normal, and it's regular, we go to our rate. Less than 60, we know it's sinus Brady. 60 to 100, we know it's normal sinus rhythm or just sinus rhythm. Greater than 100, sinus tachycardia. At greater than 150, we start calling it supraventricular tachycardia. We can abbreviate that SVT. And remember that our P's and T's are smushed together so they're hard to see. Our variations that we kind of talked about before is if it's irregular, it's sinus arrhythmia. If our PRI is what's long, greater than 0.20, or 5 of those little teeny tiny boxes, then we know it's either sinus Brady or sinus rhythm with a first degree heart block. Just remember those based on our rate. And then if our QRS is the part that's just a little bit too long or where our conduction's delayed, then we know we would call that a bundle branch block. So we'd say it's sinus rhythm with a bundle branch block or sinus Brady with a bundle branch block, depending on what the rate is. And then asystole is easy. Asystole is always just asystole. Okay? So look at this. Check this out. That is 1, 2, 3, 4, 5, 6, 7 different rhythms you've learned, and you've learned about bundle branch boxes. That is already like 1/3 of the material. Okay? So go and practice all those strips in your book until those feel easy. Okay? And when those feel easy, then we'll go on. We're going to learn 2 new rhythms, and then we're just going to sit back and quiz, and we're going to practice a little bit before we go on. Okay? The next 2 rhythms that we're going to learn are when there's sort of irritability and problems in the atria, or the top part of the heart. Okay. So the first one that we're going to learn, I have to think about which one I want to do first. So, I do them in generally the same order, but not always. The first one we're going to learn is a rhythm called atrial flutter. Okay. I actually really like the way this rhythm looks. I have 2 favorite rhythms, and atrial flutter is one of my 2 favorites. See, I told you I was kind of a dork. You know I'm a dork, because who has a favorite heart rhythm but me? So you have a spot that's become irritable, all right? And that irritable spot starts to make a loop with your own conduction system, and it will get this part going really fast. So what happens is the atria starts outperforming the ventricle, okay? So it starts something like this. This is my atria, starts going 1, 2, 3, 1, 1, 2, 3, 1, 1, 2, 3, 1, 1, 2, 3, 1, 1, 2, 3, 1. See, my atria is beating 3 times as fast as my ventricle is, okay? So what you'll see some abnormal looking P waves because it didn't start in exactly the normal spot. If it started the SA node and traveled normally down, we'd see normal P waves. But it started sort of in the middle in this janky spot. So you get these P waves that kind of look like this. Okay, so the P waves kind of look more pointy. Some references will call them sawtooth P's because they look like the little teeth of a saw. Some people call them little shark's tooth, so everybody's got a fun little name for them. But they're basically your P waves. Okay, so you have 1, 2, 3 P waves for each Q or S. If you want to sound really, really, really fancy and impress people, you could say, well, I have an atrial flutter with a 3-to-1 block. But that's not the important part. The important part is just that you have atrial flutter. So this is the first time in our rhythms where our atrial rate is different than our ventricular rate. Okay, so we can calculate our atrial rate by picking 2 of the same spots on 2 flutter waves and measuring the difference. So we could either pick the bottoms, we could pick the tops. It doesn't matter as long as you pick the same spot. So I just, wherever it's easiest for you to see on that grid. And what you'll find is that it's probably somewhere between 200 and 300 beats per minute, that the atria is really just flying along. And the ventricle is responding in a relatively normal beat. You know, it's still probably in a relatively normal rate. So you could calculate the atrial rate and the ventricular rate. Okay, try it on a couple strips. There's practice ones right there. Try it just for fun to see how easy that is to measure the difference. The next rhythm is probably a rhythm that you will have heard of on TV. Have you heard commercials? My dad's in chronic AFib, or I have AFib and I take Coumadin, or I take warfarin, or I take Eliquis, or I take this blood thinner. There's a certain percentage of our population that lives in atrial fib, so it's probably one of the more common dysrhythmias that you will see. And what is happening in atrial fib is that there is somewhere between 150 and 400 irritable spots in the atria. I mean, there's just tons, okay? 150 to 400. So what happens is the atria ends up in basically like a muscle spasm. All right, so every so often, like this little irritable group of cells will start its depolarization all by itself, and then it will trigger the cell next to it to depolarize, and that'll trigger the cell next to it, the cell next to it. It kind of creates like a wave-like action, and every so often, that wave finally makes its way down to the AV node, and then the normal conduction is followed, and the ventricle contracts. Okay, so maybe this one did it this time and it contracted, but then the next one, the stimulus came from way far up and it got there and this one contracted. So this rhythm is way, way, way irregular. In fact, when they look at the defining criteria for this rhythm, they say it is irregularly irregular. Like, how confusing is that? But there are some rhythms that are a little irregular, but they have a pattern to them. This is the only one that's no pattern with its ventricular response. It's just irregularly irregular, okay? So what we have is our spasming atria and the ventricle responding just whenever it can, but not in any regular way. Spasm in the atria kind of looks something like that, okay? But then we have our normal QRS complex. Okay, so if you see a wavy baseline and your QRSs are really irregularly spaced, you got to think atrial fib. Okay, so in atrial fib, there is no PRI to measure. There's none. Your QRS you can measure, and if it's less than 0.10, it's normal. If it's greater than 0.10, it's a bundle branch block. Okay. QTI, you may be able to measure it. You may be able to clearly see where the T wave ends, and you may not. It depends on how big those other little flutter waves are. If you can measure it, you do. If you can't see it clearly, you just put not applicable. Okay? So the defining criteria for atrial fib really is this sort of wavy baseline, no P waves, QRS response that's irregular, and that's it. So if you look in your book, there's several strips of fib and flutter next to each other. And these are usually really, really fast and easy to identify. You know, one's irregular, flutter's pretty regular. So go and practice those and see how you do. Before we go on, let's just review for a second, because this may be your second session back, or maybe you're, trying to marathon it through or something. But let's just stop and make sure you got a handle on where we're going so far. So I'll ask a question and you answer it. And if you don't know the answer, you can either find it in your book, or hopefully the instructor who's facilitating your class today will go through that. We'll pause and go through it with you, okay? So, what does the P wave represent? What does the T wave represent? What is the normal PR interval? What is the normal QT interval? What represents ventricular depolarization on our EKG strip? In using the 6-second method to determine the rate, how do you do it? How many little tiny boxes are there in 1 minute? What's the heart rate for SVT? Do you think asystole can ever have a pulse? What is the intrinsic firing rate of the SA node? After the impulse leaves the SA node, it goes to the AV node. From there, where does it go? Make sure you know where your electrodes go, what colors go where. If you don't, we'll review. Okay, so hopefully by now you're feeling pretty good with your sinus rhythms and those atrial rhythms like atrial fib and atrial flutter. If you are making flashcards, you should have at least probably 10 flashcards with different rhythms. On the front of your flashcard, you should have the rhythm strip, like cut out pictures of the rhythm strips. If you didn't get some with the packet that I gave for this class, you can go to Google and put in atrial fib and hit images, and you'll get hundreds and hundreds of strips. So you put that on the front of your flashcard, and on the back you'd put the defining criteria. So our defining criteria of atrial fib, remember, was that it is irregularly irregular, that our QRS is generally still nice and tight and narrow, but that there's no clear P wave. There's just that wavy baseline because our atria was in spasm. Okay, so you should have flashcards for all the rhythms that we've already done, and a lot of the vocabulary that we've already done. So you should have a flashcard that says PR interval, and on the back says normal is 0.12 to 0.20 seconds. Okay, stuff like that. The more you make those flashcards and the more you practice them, the easier it will be. Okay. So for our next set of rhythms, again, we have a threefer, kind of like we did with our beginning sinus rhythms, and these are our junctional rhythms. So let me show you what's happening with junctional rhythms. Okay, I got new dry erase pens yesterday. Do you like that? Better, huh? Okay, so remember our electrical system went like this. Okay, we started with our SA node, down our internodal pathways to our AV node, bundle of His, right and left bundle branches, and then out to the Purkinje fibers. In our junctional rhythms, for whatever reason, our SA node is not working. Okay, it has just gone offline. Okay, but remember, our AV node had an intrinsic firing rate of 40 to 60 beats per minute, which means if the SA node isn't doing its thing, it will pick up and go, hey, it's okay, I'm going to say this. But because our depolarization is originating in our AV node, what's happening is it's going to spread the contraction backwards through the atria and then downwards through the ventricle. But it's going to follow the regular path down in the ventricle. So the QRS that is made from this part will look the same. It'll be nice and tight. What will be different? The P waves, because they're not coming from top to bottom. They're going from bottom to top. So the defining criteria for junctional is that you have absent or inverted, they sometimes say retrograde P waves. And your PR interval is going to be really, really short. So if you have a really short PR interval, that's okay. Because think about what's happening. We're having it originate. Here's our atria, here's our ventricle. It's originating in the middle, and they're going at the same time. Okay? So a lot of times, that P wave is just lost in the QRS. But it's still really, really regular. So regular junctional rhythm, absent inverted retrograde P waves, regular, with a rate of 40 to 60 beats per minute. Here's the 3-4 part. If the rate starts to speed up a little bit, right? Your body needs more cardiac output, more blood pressure, so it starts to increase the rate, start secreting all those good hormones and things that make that happen. 60 to 100 beats per minute, but still regular, still narrow QRS, absent inverted or retrograde Ps. We call this junctional, accelerated junctional. Accelerated junctional. All of this in your material. And greater than 100, we call it junctional tach. Junctional tachycardia, junctional tach. Okay? Sound good? Piece of cake? Easy peasy peasy? Okay, you should have some in your handouts, and your instructor is going to pause the video for a second and go through those with you. Now we're going to talk about, almost made me mad. I thought it was not going to work for a second. Now we're going to talk about ventricular dysrhythmias. So things that are happening in the ventricle that cause our rhythm to be disturbed or happen when our electrical system is breaking down. The first one I'm going to talk about is a rhythm called idioventricular. If we are having idioventricular, it is definitely a medical emergency unless your patient is a do not resuscitate, accept natural death sort of situation. In idioventricular, what has happened is not only is the SA node offline, but the AV node is offline. See, look at this. What did I tell you yesterday about dry erase pens? Man, oh man. This one's two-sided. We're okay. All right, so what happens? Do you remember in the very beginning, we talked about how if we were not on the freeway, that the cells in the heart could start and generate a contraction all on their own and do it in a cell-to-cell path. It would be like taking side streets somewhere instead of the freeway. It can still happen. It can still depolarize, which generates a contraction. It's just that it's slower. It's slower and it's going to look different because it wasn't on the freeway. That's sort of what's happening in idioventricular. So if your SA node's offline and your AV node is offline, what will happen is there will be a spot in the ventricles that picks up and starts that cell-to-cell-to-cell-to-cell contraction, okay? But by the time we get down here, we're not on the freeway. And remember, this had an automatic firing rate of 60 to 100. This one was 40 to 60. So as we're going down, we're getting slower. The system's becoming less and less effective. So a spot in the ventricles is probably going to be around 20 to 40. Some references will say 15 to 30, some say 20 to 30. They're all slightly different, but you get the point that they're all slow and that's generally too slow to feel good. So what happens, we have this irritable spot, could be here, could be here, could be here. That part doesn't matter, but this irritable spot of your heart that is trying hard to preserve you and keep you going says, it's okay, we'll do it, we'll handle it, cell to cell to cell, buddies, let's get it done. So this contraction starts spreading as sort of a wave across the heart or the myocardium, and it does generate a contraction. It makes the ventricles contract, okay? Freeway is nice and tight. Side streets are wide and we say bizarre looking. So idioventricular, the beats look something like that. They may look a little different. Sometimes you can see the T waves, sometimes the T waves all smushed in there. But idioventricular is regular. So you will march out. It is 20 to 40 beats per minute. There is no P wave. Remember, we get P waves when we follow the normal conduction, SA to AV down. That part's what generates our P wave. Well, everything's going backwards, so there's no P waves. No P waves, wide, bizarre-looking QRSs, but very, very regular. Sometimes people call this the dying heart. That is probably pretty accurate. But like I said, if your patient's, if your patient's, at end of life and ready to face those things and ready for the next great adventure and, is a do not resuscitate, then this is kind of how we expect the heart to normally just slow down and let them pass peacefully. Okay, look at all the fun topics we talk about in basic dysrhythmia. Life, death, all these things. Our next rhythm that we're going to look at, remember we're talking about our ventricular sort of dysrhythmias now. So number 1 was idioventricular. Number 2 is ventricular tachycardia. So what's happening with VTach is that you get an irritable spot, makes a loop with your own conduction system, and what you get is a ventricular response that's going super, super fast, right? I call this the slinky. This is my own term, but it kind of looks like a slinky. It kind of looks like that. The point can go up, the point can go down, okay? But if you marched it out and you were looking like 5 boxes between here, 5 boxes between here, or 7 or whatever, it's pretty regular. It's really, really regular actually. VTach, patients can have a pulse. They usually don't feel great, and the older you are, it seems like the less length of time you can sustain something like this. It's not uncommon for patients to not have a pulse with this either. So if you were to see VTach on your monitor, the first thing you'd want to do is go check your patient. Remember that the leads are affected by movement, right? So if you jiggle the leads, you will get artifact. You'll get movement in there. So I do know of a nurse who ran in to check a patient who looked like they were in VTach and they were just playing games on their iPad. They were actually playing Angry Bird. That tells you how old that story is. But they were playing Angry Birds. And so it was generating a rhythm that looked like VTach, which is why the first thing you do is you always go check your patient, you check their leads, check a blood pressure, make sure your patient's okay, make sure your rhythm's real, and go from there. Okay? So that's VTach. Definitely a medical emergency. If you're in the hospital, you definitely want to call rapid response if you're not in an acute area and go with that. All right, we're going to do one more, and then I want you to practice the ones in your book. And then we're going to talk about ectopy, because that's one thing we got to get through to make this all be clear. Do you remember with atrial fib, we had all those irritable spots in the atria that were producing our little fibrillation wave, right? That's our spasm of our atria. But then the stimulus would get here down to the AV node and we'd have a normal ventricular response. Right? It was just irregular, never knew when it was going to make its way down there, right? So that was atrial fib. The same thing that happens in the atria can happen in the ventricles. Hundreds and hundreds of irritable spots, right? But if it happens in the ventricles and our ventricles in spasm, we won't see QRS. The QRS, remember the QRS is made when we follow the normal conduction path from the AV node, the bundle of His, the right and left bundle branches, down to our Purkinje fibers. If our ventricle's in spasm, we don't get a QRS. What we get is we get that same spasming we saw in atrial fib, but we get it in the ventricles too. It can look fine, it can look coarse. Okay? But there's no regularity to it. If I was trying to count the number of boxes between complexes, you're like, well, there's no complexes to count. There's nothing really to do that. Maybe I could count 5 between this and this one, but there's only 3 there, and then there's, what is that? Who even knows what that is? So in VFib, or ventricular fibrillation, the whole heart is in spasm. The whole ventricles. Okay, no contraction, no blood flow, no blood pressure, no pulse. So this is cardiac arrest. This is one form of cardiac arrest, VFib. Right? So don't confuse ventricular fibrillation, cardiac arrest, with atrial fibrillation, which can be a chronic state that people can live in just fine for a long period of time. Remember, atrial fib, it's happening in the atria, but you have normal QRS complexes. Ventricular fibrillation, no QRS complexes, nothing but this fibrillation wave. Your heart's in spasm. Call a code, start CPR, get the AED. Okay, so I wanted to talk a little bit about a few more vocabulary words before we get into the subject of ectopy. You know, like I said, there's things that you can use or that you can say to explain things in very simple terms, and then there's words that you can use that can make you feel a little crazy, or if you're got a big ego, can make you feel very smart, I guess. So one of the words that we use with things is monomorphic. Monomorphic means that there is one appearance and one shape. Polymorphic means there's more than one appearance and one shape. Okay? There's even a form of VTAC, which I didn't really cover when I talked about VTAC, but I'm going to go back and do it right now, where VTAC can have more than one shape. Okay? But you can still tell it's VTAC. It still meets the defining criteria for VTAC. Okay? Ectopy is the same way. All ectopy is are early beats. Okay? So before I go on to ectopy, let me go back and do polymorphic VTAC, because I just want to make sure those two words are in your head and that you know the difference between those. Okay? So VTAC we defined as our slinky. Okay? Essentially, every beat looks the same. Okay? The form of VTAC that's polymorphic VTAC means that sometimes they don't look the same. And you're like, oh, it flipped upside down for a little bit. The other thing that polymorphic VTAC can do is it can get bigger and littler and bigger and littler again. And it kind of, if you look at it, this one kind of gives you an hourglassy, kind of an hourglassy shape if you're looking at it on strips. Okay. You can still tell that it's VTAC. It's all ventricular function. It's all the ventricle going 160, 180 to 240 beats per minute. It's all that ventricle just going fast, 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 fast. But we could call this one monomorphic VTAC, and we could call this one polymorphic VTAC. Polymorphic VTAC has another name that is commonly used, at least in this part of the world, called torsades. Torsades de point would be the full name of it, meaning flip your point in French. But when you hear people refer to torsades, what they're really meaning is polymorphic VTAC. Torsades can be associated with people who have long QT intervals. Remember I told you there was a reason to measure that QT interval, and it's long QT intervals can predispose you towards VTAC and torsades. Torsades is also associated with certain medications. Did I say low magnesium? If I didn't say low magnesium again. So those are things that you would consider if you had a patient who was going maybe in and out of torsades. They can have a pulse. They might not. Okay. But hopefully that illustrates the point of looks the same, monomorphic, looks different, polymorphic. All right. All right. So let's talk more about ectopy. Everybody has early or extra beats. Have you ever had that super strong Starbucks coffee and then felt yourself have a little bit of like palpitations, or felt like an extra beat, or you felt your heart go beep, beep, beep? You know, you felt something. Sometimes it happens to people when they take cold medicine. If you're a smoker, sometimes smoking can do that. Anything that is a stimulant, so nicotine, caffeine, cold medicine, drugs, you know, those bad things. All of those things, alcohol can do it. Some people are super sensitive. They can even feel it with chocolate, whatever. Some people, you know, everybody's got a different level of sensitivity, but we all have premature beats, all of us. And so how do you determine a premature beat? Well, if your heartbeat is beating along, beat, 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 beat. You had extra beats in there. You had early beats in there. As long as you're not having more than like 6 of those a minute, we're not too concerned. Okay? As your heart becomes irritable, and maybe we are starting to think that you're having a problem, that ectopy might increase in amount. You might go from having 3 or 4 a minute to now you're having 12, 13 a minute, or you might even have them come in little groups. You had 2 early beats together. You had, 3 early beats together. Once you start getting 3 or 4 beats together, you actually are now having a run of a new rhythm. So it would probably be usually a run of VTAC or a run of SVT. And those should be those little red flags in your mind that my heart's getting irritable. I may be, inching towards a change from sinus rhythm or from sinus tach to SVT, or from sinus, from sinus to, VTach. Sometimes you can see those things coming. I think ectopy is hard for people sometimes, but I'm going to tell you it gets so much easier if you just practice. And I have like a 5-page handout with practice strips up the wazoo for you to practice, 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 and feel good. Okay? So I'm going to erase my board here, and then we're going to talk about the 3 places ectopy comes from, and there's only 3. Okay, I'm going to be extra fancy. I'm even going to write some in different colors. So our first place that ectopy can come from is the SA node. Right? SA node's doing its job, kicking out at 60 to 100 beats per minute. You decide to pound you a 5-hour energy drink because it's 8 hours into your shift and you got 4 more to go. Your heart's going to react to that 5-hour energy drink, and it's going to give you, it might speed up and give you an extra beat. So if you have extra beats originating from the SA node, right, you're going to have a premature atrial contraction. And it looks just like an extra sinus beat, okay? I will try to draw this for you, but I have to admit that I'm not the best in drawing ectopy. So you're having your sinus, right? You're kicking along, and then all of a sudden, maybe you have it comes a little early, okay? There was this much room on this beat, but there's only this much room on this beat between your T wave and your P wave, so you know I've been getting this much all the time. I've been getting this much all the time. All of a sudden I had one early beat, and then I went back to that, okay? So I say when you're looking at your strip, this is the way I want you to think of it in your head. Circle your beat that came early, cover it up for a minute. Define the underlying part, and then go back and say what your ectopy was. So in this case, we would be sinus rhythm with a premature atrial contraction, and you could call that a PAC. Okay? So far, so good. All right. The next place you can have ectopy from is the AV node, right? And this would be a premature junctional contraction. So this would look like a junctional beat thrown in there, right? The SA node can get excited, the AV node can get excited. So maybe you're running along with sinus, this beautiful sinus rhythm, and then all of a sudden you have an early beat, but there was no P wave. No P wave. Or maybe you saw a small inverted P wave, and you're like, oh, funky, look at that. There's my ectopy. My underlying was sinus rhythm, but my ectopy, I had an early beat, but my P wave was inverted or absent, but my QRS was still real narrow, so I know it was a PJC. Okay? So you can almost think like it like this. An extra sinus beat, an extra junctional beat. Okay? Just keep in mind when we're talking about ectopy, we're not talking about the underlying We're not talking about the underlying rhythm, we're just talking about the extras. Every once in a while I'll show somebody a strip of junctional, they'll call it PJC. It's like, no, the strip is junctional. PJC is just the early extra beats, just the ectopy. Okay, there's only one more. And it is, can you guess? Oh, can you guess? We have the top, the middle, it's got to be the bottom, right? So it is a premature ventricular contraction. Okay, and that originates from somewhere in the ventricles, doesn't really matter where, just some little spot that got irritable that says, hey, I felt that triple shot cappuccino from Starbucks, 30 minutes ago, and I want to let you know I felt that, right? So a PVC is like it almost looks like one beat of idioventricular, but it's thrown in a regular strip. So it's wide and bizarre looking, okay? So we'd have something like our sinus rhythm, and then all of a sudden we'd have a wide, bizarre, unusual ectopy. We'd say sinus rhythm with a PVC, okay? So why did I talk about that whole thing about monomorphic and polymorphic as it relates to ectopy? This is why. And this is really mostly pertaining to PVCs when we're talking about PVCs. What if you had two. What are two irritable spots? Right? Maybe one right there, one right there. Okay? Well, maybe all the PVCs that came from this spot look like this. But when they came from this spot, maybe they look like that. They look a little different. This one has a little bitty of a Q wave. You know, maybe this one, maybe they look, you know, more different. Whatever, they look different. Okay. So if they all look the same, we might say they were sinus rhythm with monomorphic PVCs. But if you have two different types, we would say polymorphic PVCs. Okay, remember how I told you sometimes there's more than one word to say the same thing? I'm just going to tell you the other set of words. I don't care which ones you use. I'm just going to tell you so that if you hear somebody else reference it, then you know what it means. Okay? So when we're saying morphic, monomorphic, or polymorphic, we're talking about the shape. Remember morphology, looking at the shape of that. The other words that they can say are unifocal and multifocal. So unifocal means one irritable foci, one irritable spot. So if I only had one and I was only getting PVCs that look like that, I could also describe them as unifocal PVCs. I had both my irritable spots. I'm seeing two different morphologies. I could say multifocal PVCs. All right? Which do you think is worse? Multifocal. That's right. The more irritable spots you have, that tells us something about your heart. That tells us that your heart is unhappy, right? And that it's more likely to, you know, take a train somewhere you don't want to go. Okay? That is ectopy. Practice, practice, practice. Did you finish your pages on ectopy? Because I want to tell you one or two more quick vocabulary words, and then we're going to go on to heart blocks, which are so much fun. Heart blocks are fun. So with our ectopy, now that you're comfortable with where it's coming from, the SA node to give you PACs, or the AV node to give you PJCs, or somewhere in the ventricle for PVCs, there's just a couple more words that you could use to describe them. And these are really easy, so don't make yourself crazy with them. Bigeminal just means you're having ectopy every other beat. Trigeminal just means that you're having ectopy every third beat. Quadgeminal means you're just having it every fourth beat, and I've never heard anybody say any word beyond that, okay? So those are just other words that you might hear, and as you get more comfortable with these, you're going to use them. You'll start using those words to describe them. It just is a little bit, in the beginning, it can feel like a lot. So from ectopy alone, you should have like 6, 7, 8 vocabulary flashcards. You should have a lot. You should have flashcards with PAC and the picture of a PAC on the front and the defining criteria on the back. It's an early or extra beat. It originated from the SA node. It has a P, a normal QRS and T. You can see all the parts. Same with PJC, that it's an early extra beat, that it does not have a P wave unless it's inverted, you know, and just inverted. Inverted or absent is really what we want to look for. But that the QRS is still narrow, and one for PVC, and all those fun words we did in the last segment. All right. Heart blocks. There are 4, and you already know one of them. The first one, first degree heart block, was when our stimulus took just too long to get from the SA node to the AV node, and our P or I was greater than 0.20. Remember that? We did those the very first time with our sinus rhythms. So now we're going to talk about our other 2 kinds of heart blocks. Okay. Second degree heart blocks, and you might also hear them described as atrioventricular blocks, whatever. Secondary heart blocks, there are 2 types, and we call them second degree type 1, second degree type 2, secondary heart block type 1, type 2. There are other names. This is one of those special times where there's other names, but let's just start with that and let me tell you what they are, okay? So second degree type 1. Our PRI is growing. It is elongating until we have a dropped QRS complex. And let me show you what that looks like, okay? The nice thing about type 1s is it's a really beautiful pattern that repeats over and over and over, okay? So you'll see like okay, so say this one is 0.12, this one is 0.16, this one is 0.22 or something, this one is 0.28. Then I had an extra P wave and no QRS complex. Then this one, it starts back over, 0.12, 0.16. This next one will be 0.22. You'll have one more, be 0.28. It's really, really predictable. The pattern happens over and over and over. It doesn't have to be 4 to 1. It could be 2 to 1 and then a dropped complex. It could be 3 to 1. That part is not important. The trick to determining heart blocks is always look at your PR interval. Okay, that is what makes them different from one another. So second degree type 1, our PRI is elongating. It's elongating, and then you have a dropped QRS complex. Basically what happens is you end up with that PRI getting so long, and then you end up with a P wave that's pretty close to the T wave, and the ventricle's like, hey, I just did my thing, I can't do it again, give me some time. So it drops that QRS complex, and then the pattern starts over, okay? So it is irregular, but it's got a pattern. We're gonna go back to black for the next one. Mix it up. Okay, second degree heart block, type 2. I think too many P's. And I think when you're looking at a strip first and you're kind of glancing across it, if you see extra P waves, that in your head is your flag for, oh, this is a heart block. There's extra P's, it's a heart block. There's something going on. My SA node is kicking out P waves, but there's a blockage in my electrical system that things are not conducting all the way through like normal. Okay, so extra P's, always think heart block. This one, you have extra P's, but the P that generates that conduction all the way through is constant. Okay, so if you're thinking of your heart, you're like, okay, extra P, extra P, extra P, but the one that generates that QRS is the same every time. Okay, so you might get something like this: P, P, QRS, T, P, P, QRS, T, P, P, QRS, T, P wave, P wave, P wave, P wave, P wave, P wave. But the PRI that generates that QRS, constant. Maybe it's 0.16. Again, doesn't matter what number it is. It's just reminding you that that one that conducted was constant. You can have 2 waves to every QRS. You can have 3 P waves to every QRS. It can be intermittent. It can be constant. I feel like when it's constant, it's super easy to spot. When it's intermittent, it's probably harder to catch. They probably all start intermittent and then move more towards constant. So any extra P waves, but that consistent PRI makes it a second degree type 2 heart block. Okay? Piece of cake, piece of cake. Only one more. All right. The last one is a third degree atrioventricular block. It's also called complete heart block. Third degree or complete heart block. In complete heart block, there is no talking at the AV node. It is completely obstructed. So what happens is your SA node is kicking out its P waves, regular, 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 right as rain. Okay? You can put them on a piece of paper, you can take a set of calipers, or you can count out the little boxes between them and go space to space to space and be like, oh, yep, P waves, P waves, P waves, all the way home. SA nodes worked fine. We'll have a spot in the ventricle that kicks up to say, it's okay, It's okay. We still wanna be here, right? And so it will kick up and it will do its own thing. But there's absolutely no correlation between the two. So every PRI is completely variable because they are not talking at all. This is the hardest for me to draw, my artistic talent. Here we go. So on that one, maybe your PRI was narrow, maybe this one, it was long. I feel like I'm messing this up already. Okay. Okay, I'm not an artist. I did provide you great ones in your book though. I've printed you out great ones. The other thing about third degree heart block is that usually the ventricular response is slow and the QRS is wide. Because think of where it's coming. If you could almost take a idioventricular and put it on top of P waves in your head, that's almost what it looks like. And that's almost what's really happening. P waves are doing their thing, they're contracting, and then the ventricle's doing its own thing, and it's contracting. They're both pretty regular. They both walk out. The P waves walk out, the QRSs walk out. It's just they're not talking at all to get that communication between them. All right, make sense? Okay. I'm going to read you my love story about heart blocks because I love my love story. I am not the first to come up with this, I'm sure, and I've heard somebody tell the story actually from the opposite perspective, but this is my story about heart blocks, and I hope that it helps them stick in your head with you just a little bit better. Before I read you my story, I am going to tell you the other names that this is called so that you might, in case you hear those, okay? Sometimes instead of saying second degree heart block type 1, type 2, they say Mobitz 1 and Mobitz 2. Apparently Dr. Mobitz who helped discover them. There was another doctor, his name was Winky-Bach. He only discovered type 1. So sometimes you hear secondary type 1 referred to as Winky-Bach. And sometimes people like to call it Winky-Bach because it helps them remember. So in type 1, you know, our PRI was elongating until we had that extra P and that dropped QRS complex. So sometimes they say, you know, I can't wink because I'll miss it. I'll miss my dropped complex. Everybody's got their own little trick in their head for remembering their heart blocks. But just know if you hear Mobitz 1, Mobitz 2, they're really just meaning type 1 and type 2. And if you hear Winky-Bach, they're just talking about a second degree type 1. Isn't that so funny how things happen? Like slang and language and colloquial stuff all happens. I love it. Okay, so here's my heart block story, and hopefully it will help you remember. I'm Ms. P. When I was young, I had a wild and wonderful love affair with a man named QRS. We were married young and never far apart. We were so close back then, never farther than 0.12 to 0.20 apart. Looking back, it's easy to see when you started drifting apart. First degree, it was only a little block in our communication, greater than 0.20. But as with all problems you ignore, well, the distance between us, the PRI, started growing with each beat until I'd wink and not see him at all. Second degree, type 1. Then it happened. He started seeing a P on the side. I tried to ignore it, but a woman can only live like that for so long. You know, P, P, QRS, P, P, QRS. Second degree, type 2. I finally told him that it was over and filed for divorce. Now, we lead completely separate lives. Our PRI is never the same. We are each on our own path. I just speed along 60 to 100 times per minute and do my own thing. He's, well, much, much slower these days. I've retained my girly upright shape and he looks, well, a little wide. But hey, that's what happens when you get a P on the side. You usually end up all on your own. Is there hope for Ms. P and Mr. QRS? Perhaps. I've heard of a great counselor named Mr. Pacemaker, and he can sometimes work wonders. There's my block story. We are getting so close to finished. We are almost done with learning basic arrhythmia. The only things we really have left are pacemakers, and then we can talk a little bit about the changes you would see in your EKG with an MI. And we'll probably end up doing 1 or 2 more little segments just on some other stuff and maybe a couple more quizzes that we can throw in there just to make sure you're ready to take your final, okay? Pacemakers are the most amazing pieces of equipment you would ever see. You know that technology in your cell phone that lets you turn it upright to side and lets you play games on your phone? That little accelerometer that's in your phone was used in pacemakers for like a decade or more before it was ever used in your phone. Okay? Pacemakers, they all have metabolic sensors that can pick up on what the patient, the one who has the pacemaker, is doing. Because what happens when you are normally mopping your floor or jogging to the end of the street to get your mail or any of those things? Any of those things increase your heart rate, give you more cardiac output, a better blood pressure to accommodate that exercise. Pacemakers do the same thing. Let me show you one, just a regular one, and then we'll talk about where pacemakers go and how they work. So pacemakers, I have a couple, and for the most part with basic arrhythmia, we're talking about implanted pacemakers, the ones that are implanted in people's skins. You can also pace people with those pacing pads that you use for your defibrillator. That's called transcutaneous pacing. Put a pad on the front, pad on the back. You can pace through those. There's transvenous pacing. They do that like on telemetry, the ICU, cath lab, the ER, where they slip a little pacing wire up through the femoral and they slip it into the right side of the heart to help pace the patient for a period of time, maybe just to get them over a little hump or, as a bridge to a permanent pacemaker. There's pulmonary artery catheters that can pace. So there's a lot of different kinds of pacing we can talk about. And there's a lot of basics between no matter how you pace, but then there's something special to permanent pacemakers. And if you're doing basic arrhythmia interpreting strips, we're probably most of the time talking about pacemakers. So pacemakers can have 1 or 2 leads. Okay, they could pace in the atrium and the ventricle. And what the doctor does is he accesses, usually the subclavian, and he sticks his little finger in, makes a pocket for the pacemaker to slid in, and then he accesses that big vein so that these pacemaker leads can go in. So there's your atrial lead. You can tell it's got a nice little curve on it, and it's going to stick up in the right atrial appendage. You don't need to know this for life. This is just interesting, isn't it? I think it's interesting. This is a ventricular lead, and this will go and sit down in the bottom of the right ventricle. Okay, they're on the right because think of it, how could we get things on the left? We'd have to access the aorta, and that would be a lot of pressure and a lot of movement. So for most of the time we're talking about pacing, we're talking about things going in the right ventricle and the right atrium. Okay, so my patient, this is my old pen, we don't want that one. My patient, let's say, has all of a sudden gone into a 3rd-degree heart block. Now he's dizzy, he's diaphoretic, every time he stands up he feels he's about to pass out because his ventricular rate is very slow. We don't know why he's gone into 3rd-degree heart block. There's common causes for everything and they are in your notes. And we can talk about those when we go through MI, but for now, let's just say he's gone into the 3rd-degree heart block and the doctors decided to put in a dual chamber pacemaker. Dual chamber, so 2 chambers, that just means we're going to have a pacemaker lead in the atria and one in the ventricle. Okay? So what are we going to see on our EKG? That's the important part. All right, so here's our lead in our atria, here's our lead in the ventricle. Now, our normal electrical system is still there, and pacemakers are super sophisticated piece of equipment. So like a motion sensor light, when you walk by it, it turns on, but then when you don't need it, it just clicks off. Pacemakers are the same way. They're sitting there watching all the time, but they're not functioning all the time. If your own heart can do it, your intrinsic heartbeat works fine, whatever percentage of the time it does, it's going to let your own heartbeat work because your own heartbeat is the most efficient at getting that blood drained from your atria to your ventricles and out to your body or your lungs. But when it needs help, it'll kick on. All right. So if I'm pacing in the atria, I'll see a pacemaker spike and a P wave. Right? It generates a P wave. It's not always quite as pretty as your body's normal P wave. Sometimes it can be a little flatter looking. That's okay. We knew it contracted. And then you'll see a pacemaker spike and a QRS. Now a paced QRS is usually wide and bizarre looking. Why? Do you know why? I bet you know why. You just may not know you know why. Remember, when things stay on our normal conduction system, they're nice and tight. When things originate from a different spot than our normal conduction system, they take longer. The longer it takes, the wider it is, right? So it looks different because it originated from somewhere else. Our lead is sitting right here at the bottom of our right ventricle. So it's not following the normal conduction system. It's doing that cell to cell to cell to cell to cell thing and spreading that contraction across the heart, okay? So pacemakers are usually pretty easy to spot. Your EKG machine will have a thing called pacer detection. If you turn pacer detection on, it will actually even make your pacemaker spikes a different color. It makes them like red or blue, so they stand out a mile away so that you know that that's what's going on. So you don't come in and go, oh my God, that's the fastest idioventricular I've ever seen. You know, you won't think something like that. You'll just think that, you'll just know that it's a paced beat, okay? So you will see a mix of intrinsic beats and paced beats often, or your patient's heart may have just gotten comfortable with, with the pacemaker and be letting the pacemaker work all the time. You can see a mix. You can see regular P waves and then paced QRSs. Well, that was a really bad one, right? Regular P wave, paced QRS. Regular P wave, paced QRS. That's fine too. The pacemaker reps, they set every single parameter on these like you would not believe. So they'll set it to track normal P waves if you have normal P waves, like you might in a 3rd degree heart block or something. And then they'll set a timer. If within, 0.20 seconds the QRS responds, let it have an intrinsic response. If it doesn't, generate a pacemaker spike, generate that pacemaker, starting, and generate a paced beat. Okay? If you ever get the chance to go in and watch a pacemaker be interpreted with the pacemaker rep, you should. The pacemaker, it looks at every single heartbeat. So they'll put a little thing that looks like a mouse head on top of that pacemaker, and it will communicate through the skin, and it will say, since the last pacemaker check, 3 months, 2 weeks, 7 days, and 16 hours ago, the patient has had 1,347 heartbeats. They had 13,483 PVCs, they had, 6,000 PJCs, and they had, it is amazing. It will tell you every little thing that patient has done and how that pacemaker has worked. Okay, so let's talk about when pacemakers do something they shouldn't, okay? Pacemakers can have 2 problems, mainly. They can have a sensing problem and a capturing problem. I don't think in a basic arrhythmia class it's important for you to be able to identify which. If you are a nurse going to be working in telemetry, the ER, the ICU, and you are going to be using temporary pacemakers where you have to set them, then it is important you know. And that is something that should be covered in probably a different class, a class about pacemakers specifically, where it gets more into depth on these things. But this is basic arrhythmia where we're still trying to just learn the basics. And I think what you need to be able to recognize is that is not normal. I should let my nurse or my doctor know, and we're probably going to have to call the pacemaker rep. That's what you need to know, okay? Let's draw my little... If you see pacemaker spikes where you shouldn't, okay? You should never see them in an intrinsic beat. You shouldn't see a spike in the middle of the T wave. You shouldn't see a spike in the middle of a QRS. You shouldn't see a spike in the middle of a P wave. And you shouldn't really see a spike right after any of those things happened. Okay? So you see spikes where you shouldn't, that's a problem. Okay? You have a patient who has a pacemaker and they have a big old long pause. Well, the pacemaker should have recognized that and kicked in and made a pace beat right there. The pacemaker should have recognized that. So pause, that's another problem. The last problem you can have is that you have pacemaker spikes and the person's heart didn't respond to the pacemaker spike. Okay? So those are the 3 issues we have. Spikes where we shouldn't have them, no spikes where we should, spikes with nothing, with no response from the heart. Okay? And if you have any of those, always, again, check your patient, make sure your patient's okay, Call for help if you need help, if your patient's not doing okay. And then let your nurse, your physician know and call the pacemaker rep. Patients do have a card when they have a permanent pacemaker that shows who their rep is. There's really only about 5-6 different companies. If they don't have their card, I would say call their cardiologist who put it in, ask them to check the patient chart. Worst comes to worst, there's x-ray codes on every pacemaker. You can get the x-ray code with a chest x-ray, although they can be hard to read. Worst case worst, you start calling those 5 different companies and say, hi, do you have this patient in your database? And go from there. I want to tell you one common myth with pacemakers, and then one little thing that you may or may not know about pacemakers that I still want to go over. You may see these magnets at times on your crash cart. Okay, these magnets are important because they're important for pacemakers and implanted defibrillators, and we'll say just a couple words about implanted defibrillators next. The common myth that many people believe is that if you put a magnet on a pacemaker, it will stop the pacemaker. That is not true. What a pacemaker does is it stops that pacemaker from being able to see the intrinsic beats. Okay? So we say that it makes it asynchronous. It is no longer operating in synchrony with the patient's intrinsic beats. So think of that motion sensor light. It's that I have flipped the switch and now that light is going to stay on, whether there's somebody there in front of it or not. Okay? I've just taken the sensing part away from it for a little bit. That is what a magnet does. Put the magnet on, pacemaker is going to beat, 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 beat at a predetermined rate. Every company has their own magnet rate. There's a variety of reasons they do it. There's a beginning of life magnet rate and an end of life magnet rate. So it's a quick way for the rep to go, battery's good, battery's not good. It's a quick check for them. They also used to have stuff in rural areas where patients could hold a little phone up to their pacemaker. It had a magnet in it. It was a little receiver piece, had a magnet in it that it could be checked remotely. When the pacemaker comes and checks the pacemaker, in their that looks like a little mouse, there's a magnet in there. So that I just want you to know that it's not that the magnet turns off the pacemaker. Okay? Big misconception. Okay, defibrillators. Implanted cardiac defibrillators can be put in for people with heart failure or people who have had instances of sudden cardiac death. If you went into, VFib at some point and they shocked you out of it and they brought you back, they're probably going to recommend putting a defibrillator into you in case that ever happens again. So every cardiac defibrillator also is a pacemaker. Right? Because if it shocks you, your heart might be feeling a little weird for a while. It might need a little extra assistance. We want to pace you. And if we're putting a defibrillator in you, your heart is probably not super, super healthy. There's probably other issues going on that you would benefit from the pacemaker. All right. What the magnet does to a defibrillator is it can suspend its ability to shock. That's all. Why would you want to do that? Maybe your patient has now decided to become a no-code and they are laying there in a bed and they are going in and out of VTAC as part of their end-of-life process, and they're fine, their pain's controlled, you've got all that dialed in, right? Because you're a good nurse, you've fixed all that. But you don't want this going off over and over and over and shocking them every 16 or 18 beats. We just don't want that. It can be uncomfortable. We don't want that for patients, right? Maybe their defibrillator is having a sensing problem. Very, very rare, but we've all heard that story of that patient that was out mowing the lawn and started to get shocked and had gotten shocked a lot by the time they got to the hospital because their defibrillator, for whatever reason, had a sensing problem. So your patient comes in with that problem, their defibrillator's there underneath their thing, you put the magnet on it, it's going to suspend its defibrillation function long enough for you to get hold of the rep and say, hey, I need you to come down. We have an implanted defibrillator that's not working right. That's all the magnet's for. The other thing I want to say is just about an end-of-life issue is that although physicians are sometimes reluctant to do it, pacemakers settings can be modified and changed for patients on hospice, for patients going through end-of-life issues, so that that device doesn't keep them going on longer than they naturally would. Doesn't prolong their life in a time when maybe they've got cancer or they've got other issues that makes their suffering more. So please know that those are options. You can always talk to your pacemaker rep about them, and I feel like we're all advocates for our patients, so we should do that. There is one other pacing thing I'm going to tell you about. You're not going to see anything different on the monitor. Again, this is just one of those things that I feel like I want you to understand it if somebody says the word. So if they say resynchronization therapy or they say biventricular pacemaker, I want you to know what that means. That is a treatment for heart failure, because as patients have heart failure, what happens is their heart sometimes becomes big and boggy and over-distended, and then as the ventricles contract, instead of the right and the ventricle left going at the same time, you get like this kind of cattywampus thing where it's going, they're not timed great, and so the septum in between them kind of becomes a little more boggy, and you don't get as good a cardiac output as maybe you used to. All right, so you can have them do biventricular pacing, and then the pacemaker reps come in and they time those two leads that are in the ventricles. They time them really specifically to help them contract in a way that reestablishes sort of that contraction together, right? That retimes them. Obviously, resynchronization therapy. Okay, and now I know you're asking yourself, you're saying, but wait, you said you can't put leads in the left ventricle, so what are they doing? You're curious, right? Okay, so resynchronization therapy or biventricular pacing, you have the lead in the right atrium, the lead in the right ventricle. Then you have this little teeny tiny blood vessel in the right atrium. Little teeny tiny blood vessel. It is called the coronary sinus. And your coronary arteries, you know, they fill with blood. And where does their blood go after they fill? It drains from the coronary, it drains through the coronary sinus back into the right atrium. Okay. You have very slick, good doctors, and what those slick, good doctors do is they put a lead right in there through the coronary sinus, and then it lays sort of across the top outside of the left ventricle. Okay, so it's not inside the left ventricle, but it's sort of across the top in this like little blood vessel, this little tube channel, and it generates the contraction from there. So they time these two leads, so they do that. So sometimes people will say, well, I see two ventricular spikes. I've never seen two ventricular spikes. If you can see them, they're not timed very close together, right? We're talking about hundredths of a second in our timing of these things. We're talking, Olympic timing. It's too much for us to really perceive those differences. But when they're doing an echo and they're timing those two leads to make sure they fire just at the same time and create that nice strong contraction, they can see it. If you ever see one where you can see two leads, you should print a strip and save it for me and send it to me so I can see it too. That's what we should do. All right, the last thing we're going to talk about is just a quick, brief little overview into 12 leads and to when we should be worried about things on our EKG. So our very, very first little segment, we talked about the different leads that we monitor in, okay? And what I think is important is to know that different leads show you different sides of the heart. Okay. Most hospitals have the ability to monitor in two leads at the same time. You would want to pick two leads that showed you different sides of the heart, right? Remember my analogy with taking a picture of me from that window? Well, you wouldn't take two of the exact same pictures through that window. You'd want a picture from that window and a picture from that window because you'd want to see both sides of me. So we have three main blood vessels that take blood out to our heart, and they can bifurcate and move into other vessels at the end. But we want to take those two pictures showing our two different areas. Make sense? The two most common leads to monitor in are in lead 2, which shows the inferior side and the right coronary artery really well, and V1, which tends to show like our left ventricular or left septal area good. Okay. Lead 2, is often our easiest to interpret in because it makes the prettiest P waves. They're really nice and upright and big, so you can see where in V1, the picture is not more like this, it's more like this, so it's not getting P waves and T waves usually that are as big, okay? So if you start having changes in one part of your heart, it's going to show in that lead, all right? That's what I'm trying to say. So that's why we want to look in two leads, okay? This point right here, we did not define it yet. It is called the J point. Okay? When the J point moves, that is something for us to think about. So if you were holding something, and you can use a piece of paper across your EKG, right? You can see that everything leaves and sort of returns to that baseline. And it has a magnet in it. Wasn't that awesome? I know, you didn't expect that. I kind of forgot it did until I just stuck it up there and it just stayed. So everything leaves and returns to that line, right? That's our baseline. I've been throwing baseline. It can also be called isoelectric line just for fun, right? But everything should leave and return to that baseline. Okay. When your heart is ischemic or not getting enough oxygen, things can start to happen. And what can happen is you can have this J point and this ST segment, so that's our ST segment, can move down. ST segment depression. The other thing that can happen is my T wave can go down. Okay? So ischemia is bad, right? Causes ST depression and T wave inversion. So sometimes what happens is that my ST segment ends up kind of in a down slope, and then my T wave can look kind of funny, or my ST segment can slope down a little bit and my T wave can start to invert. That means ischemia. That means something's going on. My heart muscle is telling me that it's not getting the normal amount of blood flow. As ischemia goes on, injury starts to happen. Okay? When injury happens, sorry, I'm moving my board. Jordan keeps coming in between every clip and fixing it for me because I keep moving it. Sorry. Isn't she wonderful? All right. So what happens as we get to injury is that my J point and my ST segment moves up. Okay? So now maybe my J point is right here like this. Here's my baseline. There's my J point. But it should have been on the baseline, and now it's moved up, and now I have sort of this upslurring of my ST segment into my T wave. See how that is? Okay, on my grid paper, remember my grids here, one box we don't worry about, okay? One box is, the difference between you and me, a little inflation, inflammation, a little something. One box is usually not something that we consider hugely diagnostic. I mean, I'd watch it, but I wouldn't be too excited. But if you get more than one box, that's probably something we should call on. We're going to expect to do a 12 lead. We're going to expect to probably do a little bit more, get a little bit more information. Okay. So in this one, you could see that my J point was above the 3 little hashtag mark, our little 3 boxes. So we would say we got 3 millimeter or 3 box. ST segment elevation. Go check our patient, make sure they're not having chest pain, chest pressure, shortness of breath, anything weird, pain in the jaw, difficulty breathing, any of those things would indicate we're having a problem. All right. All right, there is more in your book about 12 leads, but it's kind of hard to do them without showing you 12 leads and talking about them too much. And there's a lot of diagrams in there, but if it's not pertinent to where you are, we're starting to inch away from basic arrhythmia towards more advanced stuff. But whoever's instructing your class and facilitating your class, they're going to show you some normal 12 leads, and they're also going to show you which leads that you're monitoring in go with which part of the heart, because I do feel that's an important thing, especially if you're on, again, one of those areas, tele, ER, ICU, obviously cath lab. Can't forget about your cath lab, folks. Sorry about that. That you would want to monitor, make sure you're monitoring in 2 leads so that you're seeing those 2 different areas of the heart and know what's going on. The last thing I have to say, last, is that electrolytes can affect your rhythm, right? Super high potassiums can make your T waves appear more peaked or more pointy or taller. Low potassiums can make your T waves be very flat. Magnesium, calcium, those things can also affect your EKG. But again, if you're the teletech or you're the care partner, that's probably outside of your control of what you're going to do about it. But if you see a change, let your nurse know. And if you know your nurse is going to go cover potassium, in the name of science, print a strip and look at that T wave. After she covers the potassium, did you see it change? Did you notice anything different? After she gave that potassium, did you notice that maybe they have less ectopy? Potassium levels, magnesium levels, oxygen levels, all of those will affect your heart rhythm. And and will affect the amount of ectopy you see, and can affect some of the changes in the way your EKG looks. All right, I think that is about all I have to say. So we will do one more quiz at the end in our next segment to make sure that you are ready for your final and that you know what you're talking about. Okay, here's our questions that I want you to make sure that you have in your head when you go to sit down and you go to take your final test, or whether it's with us or your hospital or wherever it is, it's a good review. What is the first node in your electrical system? What is the intrinsic firing rate of the SA node? What color lead goes right here on the right shoulder? The brown lead goes in which place? Lead 2 is monitoring from which two leads? Our QRS should measure to be what? If our QS is greater than normal, greater than 0.10 or 0.12, we say that this is what? When my current travels from my SA node to my AV node, the next little piece in that system is called the... In junctional rhythms, what's different about my P wave? What's the difference in the QRS between junctional rhythms and idioventricular rhythms? In our sinus rhythms, we always have how many P's for each QRS? Make sure you know which rate corresponds to which sinus rhythm. On your paper right now, draw atrial fib and then draw ventricular fib. You just drew AFib and VFib. Which one can be chronic and fine? Which one has no pulse? Does asystole ever have a pulse? What is the PRI doing in a second degree type 1 heart block? In a third degree heart block, our PRI is what? If I see a pacemaker spike and a P wave, and then another pacemaker spike and a QRS, is this a dual chamber pacemaker? What does polymorphic mean? A normal PR interval is what? Do you have a favorite heart rhythm? If so, what is it, and define it, because I have two: torsades and atrial flutter. I need to introduce Jordan. Jordan, come here. Jordan is my amazing videographer. She has gone to college to do these crazy things, and she always does a lovely job for me. We've been friends for a lot of years. All her information is at the end of the video, so if you need somebody to do stuff for you, call Jordan, because she's going to put this all together and it's going to look great. But it will have nothing to have done anything I did. She will do it all.